Good afternoon, and welcome to a live webinar from the Population Health Colloquium occurring this week in Philadelphia, Pennsylvania. This annual conference brings together healthcare professionals, experts, and thought leaders to explore leading-edge strategies and innovation focused on population health management. My name is Greg Malkery, and I'm the Managing Director of the Spyglass Consulting Group. Spyglass is a market strategy firm focused on emerging digital health technologies, and I'm thrilled to be hosting today's webinar. Joining me as our guest speaker, Dr. Harm Scherpbier, adjunct professor for population health at Thomas Jefferson University. Harm, would you like to provide us with a few opening remarks?
Yeah, thank you, Greg. It's good to be here today with you. As you said, the last 3 days is the Population Health Colloquium in Philadelphia, an annual event that brings together many players in the population health space, academia, industry, healthcare providers, healthcare payers, ACOs, all meeting here. It was a good meeting, a very great mix of speakers, a good mix of panels. Networking is an important part of the Population Health Colloquium, so there was a lot of networking interaction going on. The focus of the meeting every year, but I think even more so this year, is how population health and value-based care specifically is having an impact on how Americans receive care and how we pay for healthcare in our how healthcare is paid for. So that was the main theme here, and I think we could see a continuous increase in the growth of value-based care and the impact it's having on healthcare providers and on patients and on providers. One of the big topics I think we'll talk about today is that the themes were care management, care coordination. How do you manage a population of patients and make sure they receive the right level of care? Social determinants. How do social determinants of health play into care providing? Health equity was a major theme, has been in the past couple of years, but specifically this year. And care settings. I think there's this realization that the setting of care, acute care, practice, or in the home really drives how people receive care and also the spending on care. So care settings is super important. I think at this point, people realize that care management, care coordination isn't as important as getting patients to the right care setting. So I think we'll talk about that today in our discussion.
Great. Hey, thank you, Harm. Well, also joining us today are our sponsors. We have Lars Anderson from Storage Systems and Keith Washington from Simplify Medical. Lars and Keith, if you could please introduce yourselves.
Hey, everyone. Thank you for taking time out of your day to join us. My name is Lars Anderson, Director of Marketing Sales here at Storage Systems Unlimited. For those unfamiliar with us, we provide, like the name says, storage solutions for pretty much any department in a hospital. Like to get involved early. I don't think any architects have ever designed too much storage. But work a lot in new builds, renovations, and relocations. So from medical carts to wire shelving to cabinetry in the room to wows, a variety of different products from a variety of different manufacturers.
Yeah, and this is Keith Washington. So Simplify Medical, so we build wows. We do a lot of cart-based mobile technology. We also like to get involved early in the design process. Our strategy is design with care for improving care. So we like to really understand requirements, deliver on best we can the technology stack at the point of care, and just also excited to be here to learn about how population health management is part of patient engagement by design.
Great. Yeah, thank you, guys. Harm, let's start to pivot our discussion now to focus on how healthcare leaders can leverage digital engagement solutions to support emerging population health programs. Harm, maybe provide us a little bit of an overview of what we hope to accomplish over the next half hour.
Yeah. So these will be some of the topics we'll talk about today. Clearly, healthcare leaders need to figure out how their organization, healthcare provider, health plan, ACO, how they support population health initiatives and how they benefit from those initiatives. All of that is based on improving patient outcomes, healthcare outcomes, but also reducing the cost of care, right? So it's not just the clinical outcomes, it's also the financial outcomes. They go hand in hand. Patient satisfaction is important. I mentioned care coordination earlier. I think I've noticed that care coordination is the main strategy for many organizations, but they are beginning to realize that just filling care gaps is not enough. Identifying the right patients, getting the patients to the right setting of care actually is more important than your generic filling in the care gaps. And I think we'll talk about that because I think that's an important shift in the way people use care coordination today. Reduce hospital readmissions. It's not just readmissions, it's hospital utilization, acute care utilization in general. So any admission, any ED visit, health systems are very much focused on how can we in any way avoid or prevent acute care or keep a patient in their home. And I think that will be a theme today. How do we care for a patient while they're in their home? How can we avoid an admission or a readmission or an ED visit using these patient engagement strategies? And all of that boils down to more efficient use of healthcare resources, which is almost the definition of value-based care, a more efficient use of healthcare resources, making sure we achieve high quality of care, but also maintain a low utilization for a population of patients.
Great. Hey, Keith, I know you wanted to have a couple of polling questions up front. So the first question, we have 2 polling questions. The first question is around patient engagement. How would you rank your organization's overall patient engagement programs on a scale of 1 to 5? 5 being excellent. All right. Second polling question. How would you rank your organization's digital patient engagement programs on a scale of 1 to 5? So now we're actually using the use of digital tools to support the patient engagement process. So if you could answer that on a scale of 1 to 5, 5 being excellent. Harm, what does the results share? What have we learned about members in our audience today?
2 things. Maybe you could take the question down, Greg. I see 2 things. In the first question, patient engagement overall, the average score was between 4 and 5, so on the higher end of the scale. And then on the digital patient engagement, the score was a little bit lower. It was kind of between 3 and 4. So I think that the finding here of the quick survey is engagement, yes, digital patient engagement, a bit more behind the curve. My perspective on that is that, yes, patient engagement obviously is one of the most important strategies to help provide patients with the right level of care. They need to be involved in that care, either patient and the family or both. Digital is much more difficult. So I'm not surprised to see the trend being slightly lower there. It's much more difficult for multiple reasons. One of them is that there are so many tools and methods and applications available. And it's hard to figure out what's the right way for patients to use the right tools. But I have one thought about this. The most common way today for digital patient engagements is for patients to use their provider portal. Provider portals have been mandatory part of every EHR. Most patients receive the logon, the sign-on. So whether your provider is using an Epic system or a Cerner system or an eClinicalWorks, everybody has a portal. And the use of portals is huge. And most patients know how to get there and know how to see their own data. So patients having access to their own data, to me, is step number 1 in digital patient engagement. Having access to your own data and being able to see your lab results, your notes, your summary of the previous visits, that is, to me, the starting point for digital patient engagement. Step number 2, again, through the portal, is interacting with your physicians, being able to send messages, receive messages back, and really be more in touch with your doctor through your portal. I see a lot of evidence that patients use portals, and I think that's the primary market. Now, where we need to go next is to say, how can we build on that? How can we now start using that ground level of patient engagement and start including more tools specifically aimed at keeping patients involved in the care for their health?
Excellent. All right, I have a bunch of questions I wanted to ask you, Harm, which will kind of drill into many of these issues. Let's start off and talk about how patient engagement can contribute to a successful population health program.
It goes back to what I think said before. It's part of population health, digital patient engagement, although I would say population health program involves not just patient engagement, but also a very deep understanding of your patient population. Where are the patients using a risk stratification where the patients who I should be spending most focus on. When I ask my students in the Jefferson College of Population Health, like, what is population health? What is value-based care? The best way I can describe that is, in a traditional fee-for-service practice, a doctor would take care of any patient who is making an appointment. Anybody who's in my waiting room, that's who I see. But if a patient does not make an appointment, doesn't come see me, they're off my radar in the traditional model. In a population health setting, that's the key difference. I'm now responsible for not only the patients who come and see in my practice, but also for those patients who do not come and see me, but are in my panel, right? Who are attributed to me. I'm either getting a monthly payment for those patients, or they are in my risk panel for patients that are being assigned to me. So the difference there is, I now, as a provider, need to not only manage the patients that are making an appointment and see me in my practice, but also those who don't. And that requires engagement. That requires engagement on the side of the provider. I need to start monitoring those patients, and it requires engagement on the side of the patients. They need to realize that they are actually being cared for by their doctor, even though they don't make an appointment to see the doctor. That, to me, is the key difference in population health, and that requires some level of engagement on the patient side.
Can you give me a little bit of insights and describe maybe the importance of design in terms of people, processes, and tools to support a population health initiative?
Yeah, that's a good next step. To do this, you can't just pick up the phone and start calling your patients. It requires that we design our processes, design our information systems. All of this is done through information systems, through electronic health records and population health management systems that identify these are the patients who you most likely should be reaching out to make sure you keep them engaged and keep them healthy, and not have them go to the emergency room. So tools, processes. And the interesting thing here is, I mentioned this earlier, that care setting matters a lot here. So there's really this focus on how can we make sure that we take care of patients in the right setting. And primarily that means shifting them, trying to prevent acute care, shifting them to care in the home. And that requires design. So I have a couple quick quotes from the population health colloquium from the last couple days.
Yeah, that'd be great.
Specifically go there. So Kara Odom Walker, she's the Chief Population Health Officer at Nemours. She says, care that can be done at home needs to be done at home or at school, right? They're primarily pediatric, so home, school, and they're really focusing on shifting the care to either the home or the school setting. Deborah Dean, medical director at Mount Sinai, they created a Mount Sinai at Home program, Mount Sinai at Home, which is kind of cool. And they're saying we're using this for rehab, for infusion care, for palliative care, and also just to be able to keep patients at home. That requires design. Creating these programs means designing the program, designing the workflow, the processes, but also, and I think we'll talk about this soon, it also means designing the physical environment. And as we'll talk more about that, is hospitals and clinics are very used to designing their environments inside their building. What's the workflow? What are the tools, the platforms, the monitors, the carts? We don't control the patient's home. And as we're shifting care toward the patient's home, we, of course, cannot start overreaching and designing the patient's home. So what I'm interested in is, like, how can we extend that design factor, both the workflow and the teamwork, but also the physical layout into the patient's home? And I think that's where today's discussion is also about. How do you design that for optimal care and helping keeping patients in their home setting?
That kind of leads to our next question here is, how are healthcare organizations evolving their population health and digital engagement strategies, especially as we're transitioning into calendar year 2024?
Yeah. It's definitely shifting, transitioning. I mentioned it earlier. I think that what we saw a lot is care management. Care management means a number of care managers, people, tracking their patients and making sure that all of them are on target with their care gaps. Colonoscopies, A1Cs, retinal exams, you name it. Following up that every patient is on target with each of those things. I think the shift that's happening is that people realize that's good work, but not every care gap matters. It matters much more that you identify the patients who are actually high utilizers of care and in high need. So the high need, high cost population. And that doesn't necessarily mean the traditional care coordination. So that is the shift I see, that the focus is much more on identifying high cost, high need patients and rethinking the setting of their care. So one thing we see there is that causes, in my thinking, the margins in acute care to tighten. There clearly is a shift away from acute care because of all these value-based care practices trying to shift patients away. You can notice it in acute care settings that it's getting harder to fill the beds and to fill the EDs, which in a way is a good thing. It means value-based care is working, that we're seeing those margins shrink. It also means, from my perspective, the widespread adoption of electronic health records makes a big difference there. We can do a much better job in identifying the best practices, identifying providers, identifying the high-risk patients. And that is all, based on the information systems we've put in place over the past 10 years that help us be much more effective there.
Excellent. You raised some really interesting points, especially as you look at different settings of care. Yeah. What are the biggest challenges that healthcare organizations are encountering in integrating these digital solutions within their population health programs, which could be across different settings of care? And how can healthcare organizations address these challenges to ensure successful adoption and utilization at scale?
Yeah, challenges everywhere. I'll name a few. I don't think I'll be able to list all the challenges that exist, but just to name a few. One of them is business model. Yeah. The old business model is based on heavy acute care, on heads in beds, on full operating room schedule, on full ED schedule. That is changing, and it's taking health systems time and effort to shift away from that and to say we have to learn to survive on a population, on providing care to a population and keeping the population healthy. That is very, very difficult. I think it's something that most health systems are in the middle of that transition, that business model transition. At the same time, there's I need to say there, of course, acute care isn't going away. We need our hospitals for acute care when it's needed. It's maybe getting less, but it's definitely needed. So we need to make sure that we maintain our acute care hospitals because our population needs them too, just less of it. I have a quote here from Rodrigo Cerda. He is the Chief Medical Officer of Independence Blue Cross Blue Shield, the Philadelphia-based Independence, and he was a speaker at the Population Health Colloquium. He also said, we are very focused, that's a health plan, right? Very focused on sending people home and keeping people home. In other words, home instead of the ED. So that focus coming from payer and at the Pop Health Colloquium tells us that is the trend we're seeing happening. He also mentioned HealthShare Exchange, the regional health information exchange, as a vehicle to help do that. And I think in many settings, in many cities, your regional health information exchange is the best way to make sure that every party in the care, especially in the shift away from the hospital toward the home, has the right data at their fingertips to be able to take care for the patient. So it's transition in business model, transition in information systems, and therefore a transition in the care model.
Well, obviously, to make this happen, we need to get buy-in from key stakeholders. Let's talk about physician adoption to start. Are physicians embracing hybrid care models, and are they integrating or successfully integrating digital tools to support patient care? And when I talk about hybrid care models, I'm referring to physicians who support both in-person and virtual care within their clinical practice.
Yeah. Physician adoption is a broad topic. Clinician adoption in general. I think the main theme still at the Pop Health Colloquium, but in general also, is burnout, documentation burden, high workloads among physicians. So that has to do with their adoption of electronic health records. Electronic health records forced physicians to do more work on their computers, more documentation, more data capture. And in a way, it shifted a lot of the workload from what used to be clerks to have the doctor do it themselves. We're still seeing the effects of that. There are still doctors who feel that there's way too much time spent on their use of the information system. I'm optimistic about the way that we can make that better through better note captures, by using AI tools to streamline the way doctors use computers, how they do their documentation, also how they manage all their work lists. A doctor has multiple work lists: messages from patients, messages from the electronic health record, reminders about clinical care. They must maintain all these queues and workflows. So I see that today provides a big burden on physicians. I see the use of AI tools helping to improve that. So population health adds to that workload. Here's another list of patients, right? Another list of things to do that you weren't doing before. So in that sense, physician adoption is crucial to make this happen. I also see, so that's on the one side, that's on the adoption side. Let me put it on the other side. The most successful practices doing value-based care do not solely rely on their physicians. Obviously, they're very team focused. They have a physician and a nurse practitioner and a social worker and a community health worker and a behavioral health worker, all working together. So now it's not all falling on the shoulder of one person, although the coordination and the teamwork is really important there to make sure that you get the right patient to the right person within that team. I think that's another answer to our burden problem, that we involve a broad number of people, including home care people, home care nurses, and in the care for the patient. It's teamwork to allow a broader set of people to deliver the care.
Excellent. Now, another part of the equation in terms of buy-in is the patient. Are patients widely adopting digital solutions across all populations and demographics? Are they ready, able, and willing? In highly affluent places like Palo Alto, we see adoption off the charts. But what about in lower income communities, Fresno, California, or Bakersfield, California, where you may have a lot of immigrant workers? What are your thoughts on patient adoption?
I don't know that I have enough data and information on other than the obvious, right? That matters. I'm not sure if I have that much information on there. One thing I see though is that it's more likely for an affluent population to be engaged with their health app. I do see. So let me put this way. There's two things in there. I see a lot of focus on social determinants of health. Being incorporated, being captured, being collected, being viewed by the provider. So that, I think, is a step in the right direction, that we're actually paying attention to it, that we're not assuming all patients are the same thing, that we're actually asking patients, do any of these apply to you? Poverty, homelessness, transportation needs, do they apply to you? And once we ask the question to say, do you need help with that? And I see health systems more and more aware of this and asking patients, where do you fit in? Do you need help? And once they say, yes, we need help, I see health systems deploying and hiring community health workers to address those needs. So I don't think it really answers your patient engagement question.
Actually, no, you hit the nail on the head, because we did find the adoption of certain technologies especially during COVID, but it's not clear cut across all demographics, right? We threw it out. It's like the shotgun effect. So we're kind of in the early stages of trying to get input on where we've been successful. We know we can be successful in Palo Alto or in Manhattan, but what about when you start to look at other demographics, especially the elderly? And I like what you brought up about the social determinants of health, which is an area that many healthcare organizations are giving lip service to today. It seems like it could be more real. Was that a common theme?
It is real
at the show?
I think it's definitely real. It's definitely real. People are collecting the data. They're presenting these questionnaires. sometimes these questionnaires are a little bit long, and I think we can do a better job because sometimes it takes the nurses too long to do the work. Sometimes it takes the patient too long. So it's backing up the health system, but they're asking the questions, and they're not only collecting the data, they're also asking patients, do you need help with this? So that's good. I have one more thing in that same space though. There's the other area of focus on health equity comes from these value-based care programs. So I'll use ACO REACH as a program. ACO REACH is a CMS program to shared savings directly for practices. The measures in an ACO REACH program are not only clinical measures, the A1C and the colonoscopy, they're also health equity measures. So for a practice to succeed in an ACO REACH model, they not only need to pay attention to clinical care, but also to socioeconomic factors that play into the patient population. So I think there's way more focus on it today, and the tools exist. I don't know it's necessarily patient engagement, but it's coming from the provider side to take into account that they take care of a diverse population and that some people may have other needs than other people. That is being addressed today.
Great, that's good news. Let's pivot now. Let's talk about analytics and AI, which are hot topics in the news. How can healthcare organizations use analytics to tailor interventions targeted at specific patient populations?
That's ultimately what it's all about. I have a limited workforce. I have limited hours of the day for my workers. So where should I spend my time as a provider or as a team? Who should we focus on? So I think analytics, the most short-term analytics means which of my patients in my panel, in my 1,000, 5,000, 10,000, should I be calling this week? Who should I be focusing on this week? That requires analytics. I see electronic health records incorporate that. I also see specific population health management systems as individual solutions do that. I think each organization should decide whether they can run this purely on their EHR or whether they implement a specific population health management solution to help steer their team toward the right patient population, the right subset, the right risk stratified set of populations. That's one part of analytics. There's a higher level. So what I just mentioned is very, very direct. Who are the patients who I need to see? I also feel that analytics come into play when, as an organization, you say, we were able to make shared savings last year. Great. Congratulate. Happy. What should we do next year? When the bar goes up, when the benchmark is higher, as an organization, how do we achieve the next level of savings? Where else can we help improve the care for this population and reduce utilization? That requires analytics, that requires understanding where are we today, where should we be tomorrow, and how do we get there? One example could be, I'll just give an example, is do we need to, I'm back to the same question we talked about earlier, do we need to shift away from filling care gaps to addressing the care setting? That is something I feel that organizations can do a better job of. They can see that care gap filling doesn't necessarily get to savings, but aggressively or specifically shifting patients out of acute care to home care, that is where that may be one finding out of analytics. So analytics to me are critical at multiple levels. The very immediate level, who are the patients I need to see, but also the more long-term level, where should our organization be? How do I achieve the next tier of savings next year and the year after?
Outstanding. Harm, I want to thank you for sharing your insights. It's been really helpful. Our discussion kind of aligns very closely with the results of a published study that Spyglass put out earlier this year, focused on digital patient engagement. The report uncovers market trends driving investments and usage models. It identifies opportunities and challenges for supporting large-scale deployments and suggests how healthcare organizations can leverage digital tools to prepare for future healthcare delivery models. To learn more about the Spyglass report and how your organization can harness the power of digital tools, I encourage you to visit my website at www.spyglass-consulting.com. Well, thanks for joining our webinar today. Focus on how health leaders can leverage digital patient engagement solutions to support population health management. I'd like to thank our guest speaker today, Harm, for his time and insights. Harm, do you have any closing remarks you'd like to make?
Yeah, I think one thing that we really didn't have enough time to talk about, but let's do it in the last minute, is as we shift patients to home, as we've said multiple times today, right? Shifting care toward the home, we need to focus on what that home looks like. How do we provide care in a patient's home? And it may be different. Some patients are at home and they're sick. Some people are at home and they're not sick. They're healthy, but they need some level of care and modeling. Those are different things. And I think I'd like to find ways to design the environment for the patients in their home, using mobile devices, using carts to keep it simple but effective both for the patient and their family, but also effective for the caregivers who go there, and somehow find a way to extend that hospital environment or the clinical environment into the patient's home and have a very predictable, efficient, safe workspace for people as we are shifting them away from the hospital into their home. That, I think, is a key topic that we should be aware of and would like to work on with the partners at both Simplify and Storage Solutions.
Well, we may have to invite you back to have a whole session on hospital at home.
I would love that. That'd be super interesting. That would be super interesting.
Well, I also want to thank our sponsors, Lars Anderson from Storage Systems and Keith Washington from Simplify Medical. Lars and Keith, do you have any closing comments you'd like to make for audience members today?
No, I mean, that was a very, very interesting conversation. It's been interesting to watch the shift out of acute to ambulatory services and now into the home. We're doing a lot of work right now with freestanding ERs as well as ambulatory surgery centers. So it's definitely shifting. But I think Harm, made a few good points that, while focusing on that, you still need to apply attention to the acute side of things. So no, very good information. Thank you.
Yeah, and I agree. I really appreciate Harm and his insights. Greg, appreciate you as always and your passion for digital patient engagement and your research, and to Lars and Storage Systems, who really, as Lars just mentioned, really are looking at partnering with health systems across the continuum in all care settings, all service lines, really bringing the design into the equation. And I love hearing about population health. I like to describe, population health, value-based care as the unified field theory of healthcare. So I think it's a really interesting topic. I love the perspective. It's just so important, just looking at it from the patient's point of view, from the provider's point of view, and bringing it all together. So really appreciate everybody's time.
Thank you very much for taking the time today, and we look forward to engaging with you again at our next webinar.